Yeah, definitely. And hello, everyone. So this is Dr. Mithila from Bangladesh, and I'm the country lead of this ACROS project from Bangladesh side. And today is a very proud moment of ours that Jamal is currently our project manager for across Bangladesh, has recently successfully completed his PhD under the supervision of Professor Rod Taylor from University of Glasgow. And he actually did a very good job in according to Bangladesh perspective, because you know we all of we know that the cardiac patients mortality is leading the NCD in all over the world. And for this, we don't have any definite, the post treatment quality maintenance or any management system like rehabilitation, or for any system for quality improvement of the cardiac patients, not even any structured follow-up system in many places, as Bangladesh is not developed in that way for maintaining the electronic records of the patients. But Jamal has already actually established by his PhD about a uh, uh, some rehabilitation model, home-based and culturally adapted rehabilitation model for the cardiac patients in Bangladesh through his PhD. And already a feasibility study has been done with other scoping reviews and systematic reviews for the Bengali version of the Heart Manual among the patients of the coronary heart disease in Bangladesh. So this was very interesting, because not there is many studies in Bangladesh regarding adaptation of this type of manuals, and under the supervision of the Professor Rod, and me and Jamal actually designed the adaptation in in our way with the mixed method study. So I feel very proud to invite Jamal Uddin to present today's session on his feasibility study. Thank you, Jamal. You can start.
Yeah, thank you so much, Dr. Mithila, and thank you, Professor Rod, for supervising me as I was in PhD student. And thank you all audience. Good evening from Bangladesh. So today's seminar session actually we will discuss on the assessment of the Bangla Heart Manual in patient with coronary heart disease and their caregivers in Bangladesh, a feasibility study. So I am Md Jamal Uddin, PhD, PGR University of Glasgow, and country project manager across project. So, today's presentation outline is the background and rationale and study objectives, methods overview, data collection procedures, outcome measures, key feasibility results, secondary outcomes, qualitative findings, then conclusion and recommendations for future RCT. So the background, like the coronary heart disease is a major cause of death and disability in low and middle income countries, including Bangladesh. And the cardiac rehabilitation is effective but underused globally. As we know that the center-based cardiac rehabilitation is very common, but nowadays center-based cardiac rehabilitation is limited in Bangladesh. Only in 2016 and 17 ICCPR survey, we found only one center, that was in Ibrahim Cardiac Hospitals, as a center-based cardiac rehab unit over there. But now, just 2015, 2025 and 26, we found that 4 cardiac rehab unit in 4 cardiac hospitals. So that was promising. And home-based cardiac rehabilitation is a promising alternative also. In my PhD, I have conducted a feasibility study of Bangla Heart Manual, which is culturally adapted from the UK Heart Manual, which is originally developed by the NHS Lothian. And I think we need to test feasibility before conducting any full RCT trial. So study objectives were the primary objectives were the assess feasibility and acceptability of the Bangla Heart Manual home-based cardiac evolution program for coronary heart disease patients and their caregivers in Bangladesh. And the secondary objectives were explore changes in exercise capacity, patient-reported outcomes, that is pre-post intervention. So the inclusion criteria were age equal or more than 18 years, post-MI or angina, planned for or admitted for revascularization, or it is maybe CABG bypass surgery or PCI, and suitable for coronary cardiac rehabilitation. And the exclusion criteria were emergency revascularization would be excluded, recent cardiac rehab participations or any kind of treatment cardiac rehabilitation, contraindications to exercise, and unable to attend assessments, follow-up assessments for pilot trial. And we have find some reasons for non-consent, lack of confidence, caregiver not interested, and stress from revascularization. So after revascularizations, they have so much stress on their conditions, financial, lots of things. So they're not interested for these reasons. So study design, we actually use the mixed method, single arm, pre-post feasibility pilot study. And the study was conducted at the tertiary level hospitals in Bangladesh, which is in Dhaka. And the patients were coronary heart disease of post revascularization, as I said mentioned that bypass surgery and post PCI. Recruitment time was June and July 2024. Intervention duration was 6 weeks, and the follow-up that was 6 months. Qualitative interviews with patients, caregivers, and clinicians. We conducted the qualitative interview for their satisfaction level and the acceptability. So I will discuss later on. So outcome measures. So primary outcomes was feasibility, study recruitment, retention, and adherence, and also find out the acceptability. That was patients and their caregiver satisfaction level by using the 5-grade Likert scale at single point 3 months follow-up. And the secondary outcomes, that exercise capacity assessed by incremental shuttle walk test, patient reported outcomes by using heart quality of life, hospital anxiety and depression scale, and EQ5D5L questionnaire. Here is the study participants pathways. So first 2 months, almost 2 months, we actually conducting screening, recruitment, and did baseline assessment in hospital, and providing the intervention before discharge from hospital, and then exclusive 6 weeks for Bangla Heart Manual intervention that has been adapted, originally developed in UK NHS Lothian. And this Bangla Heart Manual intervention we will provide this 6 months after discharge, and following each week by mobile call. And as a last follow-up, we will conduct it at home, at hospital, when they are come to the hospital, and we will conduct the last follow-up, and where include incremental shuttle walk test. And then at the 12 weeks, the study has been end. So this is the study participants pathway process. Now I would like to discuss on the Bangla Heart Manual intervention. So the intervention duration was 6 weeks. Home-based program that has been the centrally monitored home-based program. From the hospitals, the physiotherapists and nurses call them from hospitals each week. They follow their instructions before discharge. We provided the intervention and what their conditions, mental health, lots of things, and we just keep it continue to programs and facilitate them. And the components of Bangla Heart Manual is exercise training and self-care and relaxation. That was the very strong part, was the mental health part and the self-care. And we also discuss in the Heart Manual component the risk factor management and psychological support for the caregivers, how to support the patients and how to maintain their mental health part. And the delivery in hospital interaction by the physiotherapist mainly, and include the nurses, And weekly phone call, as we discussed, 6 weeks. Final hospital visit, we have conducted the, face-to-face interview, and also conducted incubator shuttle lock test for exercise capacity testing. And the facilitators, 7 healthcare professionals trained by UK Heart Manual Lothians, and I will discuss later on, because this NHS Lothian, they have trained these 7 healthcare professionals, and I was there as a coordinator. And after their training, I was again conducted the training sessions for them for Bangla Heart Manual. So I discuss later on. So for Bangla Heart Manual intervention, the materials are include the printed copy of Bangla version Heart Manual. There was 2 versions, one is larger version, one is a small version. So both versions were provided to the patients because the shorter version was more pictorial and more convenient to carry on and easy to understand. And the larger version was elaborate. And then I was also provide the animated version of 6 weeks exercise program, exclusive exercise programs. You can see here after bypass surgery, patients were using the respiratory, breathe exercise programs and their shoulder movements. And this each week, how many exercise and how much time repetitive they will do their exercise at home. So I was provided this animated version of 6 weeks exercise program, and also one relaxation audio visual version that how to manage their mental health, how to relax themselves, and also one audio visual version that was the conversation between the patients and the physicians, uh, that they are asking their questions, what they know, what they want to know from their physicians. So this kind of audiovisual version I was provided, and the Bangla Heart Manual materials was included of them, and also cardiac rehab walking program. So now comes to the Prisma flow chart, where you screen prior to the eligibility assessments, and from this we assess the eligible we find out the eligible 58 patients, and then excluded it is about 25 patients not meeting the inclusion criteria, about 10, and decline for participants is 15. So enroll 33 patients. From these 33 patients, we actually allocate to intervention for 33 patients, but 2 patients did not receive allocated intervention because of 2 patients was death in ICU due to cardiac arrest, because we will provide the intervention after procedure before discharge. So they were death in ICU. And then 6 weeks follow-up. During this 6 weeks follow-up, we found the 30 patients. 1 patient was dropout. We do not find these patients because these patients were not continue our follow-up, and maybe he went another hospitals or not. I don't know. But outcome assessment after 6-week follow-up completed all follow-up 30 patients. So this is the Prisma flow diagram. And now comes to the point of data collection procedures and timelines. So the time point of baseline, we collected the demographics, medical history, incubator shuttle walk test, heart quality of life questionnaire, EQ5D, and HERS. And during intervention, we weekly phone call, and we maintain the logbooks, adherence and progress reports, tracking, and 6 months follow-up or repeat. We collect the incubator shuttle walk test and patient reported outcomes. And final, at the point of these 6 months, we collected the satisfaction survey, like 5 Likert scale for satisfaction. And the post-intervention, we use the semi-structured qualitative interview to find out the acceptability of this manual and intervention. And data sources were face-to-face interview, medical records, phone interviews, and audio recording and transcripts. If you can see here, there's some snaps of training, facilitation of Bangla Heart Manual, intervention and incubator shuttle block test data collections. Here I was just trained them of Bangla Heart Manual, how to deliver, how to present, how to manage the data collection, lots of things. And this is the snaps for just sometimes group wise patients and their caregivers, sometimes individually to deliver the Bangla Heart Manual to the patients. And this is the snaps of implementation of work testing, uh, 2 times at the before discharge and after last follow-up. And then the summary results of feasibility outcome. So this is the important slide actually for this feasibility trial. We have three components of recruitment, retention, and adherence. And the definition, it is important for recruitment, like number of consented participants relative to the total number of eligible patients approached for consent. So we use the pre-specified success criteria. The recruitment criteria rate was equal or more than 30%. So here in my study, is 33 patients are recruited out of 72 were skinned over, and 2 months period of time, and it is about per month equal or more than 16 patients, and which is about 46% of recruitment rate. And the retention, that is the number of participants who completed the final study assessment related to the total number of participants enrolled for pilot trial. The retention rate of the pre-specified, that was equal or more than 80%. And we have 2 deaths and 1 dropout, that is about 91%. And the adherence, the percentages of completion of the Bangla Heart manual intervention components logs. So intervention adherence, the pre-specified, that was equal or more than 75%. So that was the 8 session. Out of 8 sessions, 6 sessions has been completed of this during these 6 weeks programs. That was about 70%. So we can say that it is a feasible study for Bangla Heart Manual adaptation study. And the acceptability outcomes. So level of satisfaction of patients and the caregivers assessed at 3 months follow-up, where the patients, the satisfaction level, it is about out of 5 is 4, mean 4.3, and the caregivers are more satisfied, 4.4. I think this is the I mean single time outcome satisfaction level outcome measure, and they were satisfied on our trial and the materials and lots all of things. And the secondary outcomes, the exercise capacity, we use the incubator shuttle log test, the baseline and follow-up. The baseline was 17 and the follow-up was 19. And the mean baseline in mean meter distance was 91.2. And the follow-up time we found that 155.3. We may consider differently because in this study we didn't use the control part. We just pre-post. So if we conduct the control, use the control and experimental part, so that could be different maybe. But this is the pre-post only. And then we collect the data of heart qual, physical and emotional subscale and subscale. And this is the baseline and follow-up. You can see the physical subscale. Baseline was 1.69, and the emotional subscale was 1.78, and the follow-up there is a 2.62 and 2.67. So mean difference is like 0.94 and 0.87, which is significant. And then Hertz anxiety depression scale, we use this, and similarly baseline and follow-up, and then we find out the mean difference, which is significant. And we finally we use the EQ 5D 5L. I mean, there's the 5 components: mobility, self-care, usual activities, pain or discomfort, anxiety or depression. And you also use the EQ VAS scale, visual analog scale, for the baseline and the follow-up. So that was the secondary outcomes, and then we use the qualitative findings, the patient perspective things. We use the semi-structured interview by thematical way, like in the theme number 1, that knowledge and participant practice of home cardiac programs. There's 80% patients are actually mentioned that they have learned about cardiac coronary heart disease and the treatment options. They can understand about this, and then improve the understanding of self-management, self-care management, diet and relaxation part. In this theme 2, we use the self-motivation and follow-up plan. In the followed data chart, diet chart and exercise schedule. They said that they followed the data chart, diet chart, nutritional part, and also exercise schedule. Weekly phone call are encouraging, motivated to regain previous functioning. And overall comments are, we did some exercise, good to know the importance of this self-care management, diet and relaxation. And we similarly, we use the, for the clinician, on the basis of systematic and comprehensive approach. So it is about 91%. Clinicians said that the program was, the materials and program was sequential program delivery appreciated, and clear education regarding exercise, diet, and stress management. The theme 2, motivation and involved clinical practice. So clinician motivated to continue the approach, and the caregivers involvement seen as a major strength. So overall, their comments were, generally patients were excited about the program. Involving caregiver is a great idea. Then the strength of this study, actually the mixed method design, qualitative and quantitative, and diverse perspective from patients, caregivers, and facilitators, clinicians involvement, and the pre-specified feasibility success criteria for recruitment, retention, and adherence, and the high retention and adherence rate, and the culturally adapted intervention version of Bangla Heart Manual. This is the strength of this study, and what are the limitation actually? And the limitations, like the study was in a single center study. It was in urban territories hospitals. That is limited for generalizability. No control group, cannot isolate for cardiac rehab effectiveness. A small sample size in context of large trial, but for pilot trial pre-post, which is okay, but for before larger trial for piloting, which is important to increase the sample size, and the follow-up, shorter follow-up, no long-term data, self-reported outcomes, sometimes potential reporting bias come out, and no patient public involvement. And then this trial, we didn't use the patient public involvement procedure, PPI. So that was the major limitations of this pilot trial, feasibility trial. And what are the recommendations for future RCTs? So multi-center design, including urban and rural care settings, which is important for before go through the RCTs, including a control group receiving usual care, larger sample size powered for clinical outcomes, longer follow-ups, at least 6 to 12 months, including women and diverse populations in a ratio basis, blinded outcomes assessments, patients and public involvement, and cost-effective analysis for the health policy. In conclusion, Bangla Heart Manual home-based cardiac rehabilitation program is a feasible, acceptable, and safe, and made all pre-specified feasibility criteria. That was recruitment 46%, retention 91%, and adherence 75%, which is demonstrate the promising improvements in exercise capacity, also the health-related quality of life and psychological well-being. Considering recommendations, a full power multi-center RCT could possible if we consider the recommendations. Thanks for your patience in hearing me. Thank you so much. If you have any questions, please ask me. I can try myself best. Thank you.
Thank you so much, Jamal, for your wonderful presentation and a very actually nice work indeed. So to the audience, if you have any question to ask to Jamal, so please.
We have a hand up from Atta.
Yeah.
Please unmute and yeah, go.
Can I stop sharing or I just maintain this sharing?
Sorry.
Stop sharing, then we should be able to see who's got their
Yeah, if you stop sharing your screen, Jamal.
Yeah, thank you so much.
There we go. Bilal has his hand up and Atta Mohammed has his hand up. So you choose, Jamal, who do you want to talk to first?
So yeah, Atta, you can ask me.
Atta, go for it.
Can you hear me, please?
Yes.
Okay. Thank you. Thank you, Jamal. Well done. This was very good. I was just thinking, what do you learn from the adherence point of view? How much further training patients sometimes need to get better results? So, do you think that this level is fine for this feasibility study, or we need to improve the training material and some kind of trainers training?
Thank you so much. This is a great question. Actually, the training materials, I think there is a huge option to develop improvements for adherence, and also very important to train the professionals, given the training to the professionals who are conducting the intervention to the patients directly, which is very important. This is the real factor to motivate the patients to continue the session for a long period of follow-up.
Thank you.
Thank you. And then who is?
Bilal, I think, had his hand up.
Yeah.
Yeah, thank you so much, Jamal, for sharing your experiences. I have two questions. First, I will be very happy to hear that what are major challenges you face during this study. And my second question is relevant to that what I experience here in Pakistan, that some of the female participants who are have old age, like 60 plus years old, so they have very difficulty in reading and understanding the text. So what we can observe that they need a caregiver, and for a caregiver also need a psycho education session in initial. So I will be like to hear that like what you can did in Bangladesh for those participants who are like 60% and they can't read and can't understand the text.
Yeah. Yeah. Thank you so much. This is real, I mean, practical questions. That first of all, there is a challenge to continue take the follow-up. And that time in Bangladesh, there was a political chaos, and that was a very difficult situation. Everybody is were mentally upset. But the good thing is that as we conducted in a by using the mobile phone for distance, I mean, home-based programs. So the patients, so when we call them, we also treat their mental health for the political situations that before we call them, we just keep concentrate them in their health, not considering any other parts. And the follow-up maintaining is a challenge, but especially that was a 3 months follow-up, but for long-term follow-up could be more difficult. But as we are using the keep continue with the connected with them by using the mobile phone or smartphone in the future, that could be, I think, very helpful for to maintain the follow-up. And regarding your the female and their educational level and the caregivers perspective, I would say this is a real fact. Though I was conducted at the Ibrahim Cardiac hospitals, and most of the patients are a little bit more educated rather than the peripheral or any government hospitals. But the caregiver involvement, which is very important, as the physicians and clinicians repeatedly said, that this is the real fact that when we involve the caregivers, they can take charge. As you know, that the family structure of the Bangladesh in context of Pakistan, maybe there is a very closely connected with them. Like when the husband was affected, the wife were so much dedicated, and the family members are so much dedicated to them. But so this is the equally important for the patients and the caregivers to make them understand the manual. So that's why if either patients are not able to read properly, but if you deliver properly during the intervention, deliver before discharge, if the main component define them and make them understandable about the psychological part, and continue the the mobile call by explaining, which is may be helpful, but even it is considerable to think about their educational level and how to manage themselves. I think Belal, is it?
Yeah, thank you so much, Jamal.
Yeah, thank you.
Yeah, at this moment, I just want to add that uh, regarding the acceptance and regarding the actually continuous follow-up, one thing is very important that involving the family members. Even we saw that in two patients, their son was there in it during the other processes. And another thing is Jamal actually uh, converted the 200 pages manual into a short actually booklet type with pictures and also the video animation, which was actually very helpful for the for especially the video with the Bengali titles and Bengali dubbing, that what patients should do regarding the exercise picture also. And that's the exercise video. Clear? Just to see the video, if you can actually just, I don't know that if you can present it now. So that
Yeah.
was also important. That is also important that you culturally adapt your the heart manual, and it was very helpful, I think, and also the telephone conversation. But as Jamal said, it was only one center and it was a private setting. So this time in Across project, we know that we are motivated by actually Jamal's study in Bangladesh. It was a pioneer study, but this time there's a 3 center, both government and private setting, and also the more patients, about 1,000. It would be, we don't know that we will know about in the pilot trial that what will happen. But definitely his short booklet and the process and he followed definitely will lead us to do the pilot trial successfully. Thank you.
So as you, Dr. Mithila asked me to uh, play the animated version, I can try. I have this.
Ah,
It is working. Is it working?
sort of.
Yeah,
I think it's working.
It's
I
a
can, I can
slide.
see it. It's not moving. Oh, yeah. Okay.
Is there any sound, Jamal? There is no sound here.
Mm.
Can't.
Jamal, that's great. I
Yes.
think everybody's probably got the idea of it now.
Yeah.
Yeah.
Yep, that was really good.
Sorry.
Really
Yeah.
good.
Thank you. Thank you so much. Actually, I think it's given
Oh.
idea of.
Dilip has his hand up.
Yeah, I want to say something. The video, whatever the lady is doing the exercise, I think it should not the culturally appropriate. It little bit like Pakistan, South Asian context, salwar kameez or the futwa or the little.
Yes.
Yeah,
Yes.
so
You are right. You are right. And when this is the actually when I prepared this with the support of the software software
Right.
engineers. So I said him, but when the first part that was very Western, but it was little bit try to give the the cultural adapted, but it was not properly as Bangladesh or Pakistan part of dress. But yeah, it is a point of to discuss on this, that
and also
how to modify.
yeah, if you little bit give a description like that, they should wear the comfortable dress before doing this kind of exercise, because should be loose fitted dress to do this kind of exercise. This is
Okay.
very
Okay.
important. So yeah.
Yeah, so that was actually the I just give little bit faster, that the whole video animation was very large, and that was the first part. We discussed a little bit about this in how to conduct, how to do this. So I think that's why we escaped this part, because it was a very large animated video. Thank you.
Thank you all. Is there any comments or questions from the audience?
You can also put them in the chat if your connection isn't so good.
Yeah,
So
Caroline.
Hi there. Well done, Jamal.
Hi,
Congratulations.
Caroline. Nice to see you. Yeah, you also contribute lots for this. Yeah, thank you. You can ask me.
I have a question as well.
Yeah.
The people that didn't want to take part, one of the reasons for non-consent was because they were too stressed. And
Yeah.
was that just one person? Can I clarify, or was that more than one? Because I was just wondering,
Yeah.
for the future, that we would hope that the Heart Manual would be perfect for those who were stressed, because we
Yeah.
would,
Yeah.
that was
Yeah.
be one of our aims,
Yeah,
to
you're right.
actually
Actually,
reduce that.
Yeah. Thank you so much. This is very important question, that they didn't consent, basically of who are given plan to do the PCI, and the PCI, Parkinson's coronary intervention, that was the only 3 days of hospital stay. So these 3 days, that was lots of things is doing. The first day they admitted, and the second day they have been insert in the PCI in their heart coronary arteries, and then third day they have been discharged. So during this time period, patients and their caregivers were so much stressed, lots of things is going, lots of tested, echo test, different kind of test, and financial part also involved. So that time, some of the patients were not, and their caregivers, they are not interested to give consent for engaging on this pilot trial. That was actually mentioned here.
Thank you. It's interesting because one of the things we've found in the UK Heart Manual, at the beginning, people were having bypasses. That was lovely because you had 5 days to give the message over. But now people are in and out, in one day, and that's a real challenge to get that message through. So you can lose people that way. So that, yeah, it's be good to see how how we get through that in the next studies.
Yes,
Thank you.
you.
Thank you, Caroline. And so I don't think that any other questions, or I can't clear, is there any hands up? No. So
Not that I can see. No.
yeah. Then any comment from Professor Nusrat Hossain or from Professor Rod Taylor at the end last?
Yeah.
It's I think excellent work. It would be so helpful for the pilot project. So well done, Jamal.
Thank you, sir. Thank you so much.
And just to echo the same to me, so Jamal, be prepared to be embarrassed. So in life, you are sometimes blessed to work with great people. And Jamal is one of those great people. So not only am I very proud to be one of his supervisors, as Mithila was, and see him successfully complete the PhD program, we're also now blessed with the fact that we have Jamal's energy and enthusiasm and drive assisting Mithila in Bangladesh. So again, Jamal, thanks very much for the presentation today. Absolutely fantastic. We are continue our journey together because we've got lots to do in Bangladesh, right? Lots to do. Thank you.
Thank you so much, Lord, and thank you, Nusrat, for all the comments, and thanks, Jamal, for this presentation. And with this care, we can just end today's session. Thank you all for joining us and for your patience, hearing, and attendance. Thank you so much.
Thank you. Bye-bye.
Thank you. Goodbye.
Thank you.
Bye-bye.
Bye-bye.
Bye. Thank you, Jamal.
Bye-bye.